Kara, do we need to do another roll call or can we just resume?
I think because this was just such a quick break and perhaps we're going to have another one for treatment and complications, I think we can hold off on the roll call for this break.
Okay, so we'll do that perhaps before the vote. So I'll turn it over then to Carol Greenlee and Paul Conlon for the Treatment and Complications Subcommittee update.
Bill, this is Paul Conlon. I'll lead this discussion and Carol will supplement it. May I have the next slide? I'd like to thank all of the dedicated and hardworking members of the Treatment and Complications Subcommittee for everything that they've done, led in large part by my co-chair, Dr. Greenlee. It's been a tremendous period of work, and I think we've accomplished a lot. I'd also like to thank the Commission for the feedback provided and the scores for the recommendations that we've put forward. The vast majority were very supportive. We have identified a few that I'd like to bring to your attention for discussion. Next slide, please, where there may be some room for revisions and your input will be valuable. And they come from three categories for which the subcommittee had working groups, and then one recommendation, the last one, was a byproduct of the access and care delivery work group that Dr. Herman chaired. So the first one is going to deal with diabetes self-management, education and support research. And if we could go to the next slide. This recommendation actually was initially presented as one of our first draft recommendations from the meeting that we had in September of 2020. It's gone through a series of vetting, iterations, digesting, and revisions. The background for this recommendation is that DSMES, which is referred to which is the term that is more general that refers to diabetes self-management, education, and support. And I'm going to be using the term sometimes DSMT, which is diabetes self-management training, which is the Medicare term used to describe the covered benefit for basically DSMES curriculum. It is relatively poorly utilized. Uptake of DSMES or DSMT, the Medicare benefit, involves single-digit percentages of people with diabetes, but yet there's more than adequate evidence to show that it has favorable effects on patient outcomes, including tangible benefits on heart outcomes. It's really not known why uptake is so poor. There are lots of ideas, many of which are probably reasonable to assume, that include access to programs, ability to get to programs, particularly if they require face-to-face contact, the ability to afford even co-payments for programs, and the fact that some programs may be geared above people's ability to digest the material. And so we put forward a recommendation that we thought this was ripe for additional research in order to better understand what some of the barriers are, and therefore to be able to inform ways to overcome such barriers to get more people to participate in DSMES. So the next slide shows the recommendation that we presented, and I'll read it and seek your input. We recommend that the National Institutes of Health prioritize funding for research to identify and address factors that affect referrals to the patient uptake of diabetes self-management education and support, such as patient, clinician, and system-level barriers, quality measures, and incentives, and patient perspectives. The latter term, patient perspectives, was tweaked as a result of some feedback we received in response to the scoring, where a commission member had felt that a previous wording of patient-reported outcomes may not have been clear. So that phrase was modified slightly. Let me now open it up for discussion and feedback.
I don't see any hands raised, Paul.
Okay. I'll mention as an aside, here in Boston, we're having a thunderstorm go through, so you might hear thunder in the background. You can assume that's just affirmation of the recommendations. Why don't we move to the next slide? So another recommendation that I'd like to bring forward for your comment and feedback is one, again, that was first presented at the September 2020 meeting that relates to diabetes technology. We received a substantial amount of feedback from key informants and stakeholders that suggested that access to diabetes technologies, and that is subsumed, that term subsumes continuous glucose monitors, insulin pumps, and all devices that assist patients in managing their diabetes. Access is limited in many cases due to substantial administrative burdens that are placed on patients and clinicians who wish to prescribe them. And in particular, with several anecdotes, we received feedback that there is inconsistency in the way CMS eligibility requirements are interpreted and therefore applied to patients receiving such devices. And that we feel that there needs to be an evolving process that has such eligibility criteria routinely updated, revised as is appropriate based on evolving evidence, based on new technologies as well as new evidence for older technologies. And so the next slide presents a summary of this, thanks to the work of Dr. Bill Chong. And I'll read this and then invite Bill if he has any additional comments. We recommend that CMS update current eligibility requirements for various diabetes technologies and establish a process for regular evaluation of the eligibility requirements. And we specifically said at least every 3 years, leading to a national coverage determination for different diabetes technologies. In evaluating the data to revise eligibility requirements as part of the coverage determination, CMS should evaluate current evidence and consider both glycemic benefits and non-glycemic benefits that include patient-reported outcomes, such as quality of life and diabetes distress. And CMS should ensure that eligibility documentation reimbursement requirements are clearly defined and that they are consistently applied across all parties involved, including Medicare administrative contractors and auditors. And albeit not contained in this recommendation, that last statement about having consistent application is really something that came through in some of the feedback we received, including anecdotes from actual patients in which contractors and auditors applied standards that in some cases exceeded the letter of the requirements and placed those additional burdens on patients and clinicians, making it more difficult for people to achieve or sustain use of the devices. So, Dr. Chong, do you have any additional comments about this recommendation?
Hi, Paul. This is Bill. I don't have any additional comments. I think you've done a very eloquent job of outlining the background and the recommendation, and I look forward to hearing what feedback people have.
Okay, not hearing any, Bill. Please feel free as you wish. This is open now for comment and feedback. Dr. Marks, do I see your hand raised?
Yes, thank you very much. Clarifying question. There is a process through which coverage determinations are made by CMS, and that process is authorized in statute and then described in federal regulation. And I know the Commission is well aware of this. Is the recommendation then to Congress and the HHS Secretary to essentially create a parallel process that is specific to diabetes technology rather than the existing process? Over.
This is Carol. I'm gonna jump in. The real essence of the recommendation is that the current eligibility requirements for most devices are not evidence-based. They're based on things that are sometimes almost nonsensical. And so the real essence is to bring it into more evidence-based requirements, to update it more frequently, and to consider the non-glycemic benefits as well as not just changes in A1C. But the current eligibility requirements don't make sense. They're not based on what makes a difference for patients. Does that make sense, Barry?
I understand the statement. So in essence, is the answer yes, that this proposes to create, in essence, a parallel framework that is specific for diabetes technology?
I don't know that it creates a parallel one. Many of the eligibility requirements are actually generated at the Medicare administrative contractor level. We're just asking that they be updated to not have these sort of arbitrary criteria, that they're evidence-based criteria, and that they keep up with the evidence. But we're not asking, okay, now we have two processes, the normal NCD process and now the second. That's not what we're asking. Bill Chong, do you want to jump in?
Can people hear me? I've been having a little trouble with
Yes.
Right. Yeah. So Dr. Marks, I guess where we were hearing things was that the coverage determination are not updated frequently enough, and I can't remember the specifics about sort of the details of the process on how that gets made. Like, is there a regular process for updating? Is there not? I think with respect to the question of whether it's a parallel process, I think the idea was that we still want CMS to be able to consider all the factors that they consider. Wanted to highlight a few things that we think are important to consider beyond just the glucose effects of the technologies in the determination process. So I think at a high level, we think that the coverage determination process would be the same, but the nuance of adding a regular recurring reevaluation, if that process doesn't exist, then I guess in the simple a new piece, and whether that is a parallel process specific or it is just a modification of the existing process for a specific area, I guess that maybe is more of a semantic argument.
So Barry, this is Paul. If you could advise us about if this is unclear or will be interpreted differently, if it was to be directed to CMS, we'll need your help. But I think the overwhelming consensus is that the criteria for use of or access to diabetes technologies in many cases is out of date. The updating process for eligibility is haphazard, and that there's no mechanism to suggest that such a review will occur with any periodicity as technology moves along. Like, as an example, some of the criteria that were used for diabetes technologies actually go back to the DCCT trial, which, as you know, was published in the early 90s. and was an extrapolation of the fact that in that trial, patients did 4 times a day finger stick testing, and therefore it was just assumed that that was necessary and has been carried forward ever since. It's recently been modified, but again, that was a seemingly random event.
So, Barry, this is Bill Herman. So there is a national coverage determination mechanism for things like test strips and shoes and orthotics for people with diabetes, I assume. Is your question whether the technology should be carved out separately from that other ongoing process? And what would be the advantages of including everything relevant to patients with diabetes in this coverage determination?
Yeah, thank you. Actually, I was asking my question to clarify what the Commission's intent was with this recommendation, given the fact that there is an established process for determining coverage that includes national coverage determinations, as well as the process through which NCDs are appealed. And so it was unclear to me whether this recommendation dealt with addressing specific operational elements of the current process that were of concern, or whether this was advocating for a different process than the one that currently is authorized in statute and described in regulation, specific to diabetes technology. So it was really my seeking to understand what the intent of the recommendation actually was. And I'm more than happy to forward the link to the entry in the Federal Register that describes in great detail what the coverage determination process is, if that would be of value to people.
This is Carol, and Bill Chong and I have read that extensively. This is probably one of the most asked for by the public and the people in the diabetes world. This is a huge frustration. For instance, for someone with type 1 diabetes to get on an insulin pump, they have to have a low C-peptide. There's no evidence that shows that there's any validity in that requirement for eligibility, or they have to have positive antibodies, and that also doesn't indicate their success with an insulin pump. So, and it just goes on. So the number one thing is to update the current eligibility requirements so that they are actually evidence-based and using not just glycemic. So that is the number one thing. And then that because diabetes technology is evolving so fast that it needs to be done more often, as Dr. Conlon mentioned. And then the third thing is that the wording of the NCDs is vague. So, for instance, once you get on a continuous glucose monitor, you're expected to come back in to see your primary care or endocrinologist every 6 months, and they are to determine if you are effectively following the care plan. So the different vendors and auditors can differently interpret what that means. What is required to say that someone is following the care plan? So one auditor might demand that a vendor or supplier have all sorts of evidence, and then that vendor and supplier goes back to the patient and the physician saying, you need to give me all this data. So also clarification, and of course we spell that out in the report, but it is not to say we want parallel processes. That would just make it horrible. We want to say do something now to make the eligibility requirements have some evidence base to them, because they have no evidence base. And this is something people have been asking for for a long time, and it hasn't happened. So if you can help us reword it so that that's more clear, that would be welcomed. But no, we don't want two separate processes unless maybe, the MACs don't want to have anything to do with updating and becoming evidence-based in their requirements and clarifying what they mean. Then maybe there's needed to have some overriding process over them. But it is the fact that for many, many years now, these eligibility requirements have not been meeting the needs of patients. And this is a barrier that keeps people from getting things that actually help improve their control, often more effectively than expensive medications.
Thank you for the clarification.
A question, Barry, is the place where it seems like there is the concept of a parallel raised up by the regular reevaluation? Is that because I recognize that there is a process, a request to update the current requirements for the different various diabetes technologies can be done through an NCD request. Is your question about, is this a parallel process related to the proposal to have CMS on a regular basis proactively evaluate whether or not the NCD is up to date or needs to be revised?
Yeah, thank you for that. I think, again, this was my attempt to understand what the intent of the recommendation was, and whether the recommendation was describing recommended changes, if you will, or at least recommended considerations within the current coverage determination process, or whether what was being proposed by the Commission was a standalone process or a separate process or parallel process that was specific to diabetes technology. As I read the recommendation, that was unclear to me, and that's what I was seeking clarification of.
So, Barry, this is Paul Conlon. I think what I'm hearing is not necessarily disagreement with the spirit, but maybe being unclear about the actual process for how this might be affected. I might suggest that given that what we do is we move forward, and that you could probably provide guidance as to how we might better word this to make it clear. I'm not hearing disagreement about what we're saying in terms of the rationale for having a process to review, update, and determine eligibility at some regular basis. Is that correct?
I think that there's opportunity there to look at those issues in the context of the current process and statute and regulation, Paul.
And whether it would apply to other diabetes issues other than just technologies, so other supplies and equipment.
Okay, so the spirit of this recommendation dealt with diabetes technologies first and foremost. That's not to say that potentially it might not be broadened a bit as appropriate to include other, we'll use the word broadly, devices to aid people with diabetes if it turns out that there's evidence that they likewise have administrative burdens, inappropriate eligibility, or lack of updated eligibility criteria and or misinterpretation of criteria by MAC and auditors.
Thank you.
Okay, so I think that what we were dancing around was more process and not necessarily the gist of the recommendation. So if there's no objection, I'm going to move forward. Thank you for your feedback. So the next slide is a recommendation that we're going to discuss that arose from our TeamBased Care work group that Dr. Sherry Boland chaired. And actually, I'm remiss in not acknowledging in an earlier slide where we talked about DSMES, the hard work of Jasmine Gonzalez for leading the work group on diabetes self-management education and support. So I apologize for not previously acknowledging Jasmine. This group worked on a whole series of recommendations related to community health workers. The recommendation that we wanted to bring to your attention for comment and feedback is based on the fact that there are a series of social determinants of health are obviously barriers to people receiving and benefiting from diabetes treatment. And there's ample evidence that community health workers may facilitate that process by the fact that they provide a bridge between the clinical care team and the patient, representing the patient's interests and community. There are a variety of policy documents that have supported reimbursement for community-based services such as community health workers, but they are not always interpreted in the broadest of senses by states, since most of this is in the Medicaid domain. CMS has also published some recent guidance in a document called a roadmap that is at least encouraging the use of social determinants of health as a means for addressing these issues for Medicaid beneficiaries. And CDC has provided some technical assistance. But it's clear that community health workers are not being utilized optimally and regularly, potentially because of reimbursement mechanisms. And so we wanted to use some of the promising policies and programs that have been promulgated in order to enhance the use of community health workers. And the next slide articulates that in a recommendation. And the recommendation is we recommend that steps be taken to enhance implementation and sustainability of community health workers as critical members of the diabetes care team. And specifically, with directing CMS to clarify and build on 2013 rule that expanded the scope of Medicaid reimbursable services for community health workers to include social, behavioral, and economic support as part of the covered services. And again, as further clarification of that, to clarify that Medicaid funding is available for community health workers to address social determinants of health, to clarify that community health worker qualifications should focus on life experience, interpersonal skills as a natural helper, and community membership, as well as formal educational clinical training, and to develop policies that require that community health worker services be delivered in accordance with evidence-informed standards as developed by a series of agencies. And then lastly, we propose that CDC be provided with increased funding to expand programs to assist all states in the infrastructure and processes to integrate community health worker services in a comprehensive whole person approach that includes all of those social determinants of health, such as economic, behavioral, and social supports, in addition to clinical and preventive services. So this recommendation I present to you for comment and feedback. And Dr. Sherry Boland was instrumental in helping to draft this. Sherry, do you have any additional comments regarding this one?
Nothing from me. I know Carol did some rewording, but I think it's fairly similar to what we've had before. So she may want to comment more than me because I was out last week, and I know that you guys discussed this at the meeting.
Carol, any additional comments?
I'll just say that a lot of the updated wording, we had assistance from the CDC on that wording and really appreciate it since they're intimately involved with the work around community health workers, especially in as part of the diabetes care team. So we felt that they felt and we felt that the life experience, interpersonal skills as a natural helper, and community membership were important, but also some education and training. So that's why we have as well as there. Somebody suggested we put not and not formal education and clinical training, but we felt that was important. And this really is that clinical to community connection. It also is whole person care. So we want that economic, behavioral, and social support, but it can be tied into those clinical and preventive services, like helping people get to the eye exam or get a urine microalbumin. But they may have to address other issues that are more life-threatening, I should say, like lack of food or lack of housing. So anyway, we would like to know, several people had comments recommending changes to this, so we would like to know what those were.
This is Bill Herman. On the last bullet, it's unclear what the CHW services are to be integrated into and for what purpose. So it says integrate CHW services. Is it into clinical care? Is it public health programs? Is it diabetes control programs?
It's team-based care, so in a variety of settings, so we can work team-based care in there. Pat, do you want to say anything about that?
No, I don't have anything to add to what you've already mentioned.
And the CDC, though, doesn't...
Go ahead. Would team-based care solve Dr. Herman's concern about what it's being integrated into?
I believe so. I mean, that's a term that is frequently used. I don't know how specific we need to be there. Team-based care, as you pointed out, can be used in a variety of different settings.
And does CDC deliver care?
No, we do not, but we work with a variety of partner organizations and fund organizations who work to improve team-based care.
And Bill, as you probably see from the first line in that sub-bullet, this is for CDC to provide assistance to states in infrastructure for the integration of community health worker services in those states. So not CDC is not providing the care, but actually providing the support for that service to be integrated.
And how are the states, though, providing the services then?
Well, maybe through their Medicaid program or some public health services. Right now, it's only I don't know if the right word is. I was going to say isolated initiatives, and that's why we say assist all states. But Pat, can you help clarify for Dr. Herman? I know that all state Medicaid can certainly benefit from having help, but also public health.
Right, yeah, and we fund primarily, currently at least, state health departments. State health departments work with, a variety of partners, sometimes Medicaid, sometimes healthcare systems, FQHCs, other organizations in their states. And we currently are funding states to help develop that infrastructure, statewide infrastructure, to help sustain and kind of embed community health workers into, so that they have sustainable payment, all of those things that will allow them to be hired by organizations and be there long term, as opposed to volunteers or hit or miss sort of situations.
Good. So that makes sense, but I think a greater level of detail in the recommendation in terms of where the money is going and how it's being used to support team-based care would be helpful.
We plan to put that in the report, but we can work to, we already were working with the CDC around the wording of this, and we can work on that last line a little bit more. But the detail, we were going to put all the detail not in the big recommendation, but in the report.
Yeah, we could consider changing, like where it says to integrate CHW services in team-based care. Maybe that would be a way to make it more clear about the team-based care. I agree that this is different depending on the state, so I don't know that we want to get so detailed in the actual recommendation. But Bill, do you have some suggestions beyond in terms of specificity?
No, so to integrate community health workers into team-based care provided by and the types of organizations that CDC would be working with to deliver team-based care.
We don't want to restrict, we don't want to limit them because in every state they can be different. So
yeah,
we've been trying not to limit. Yeah, by
we could describe more in the report. I think we'd be a little bit premature maybe to specify that in the recommendation itself.
Although what I'm hearing, Dr. Herman's comment sounds like it might provide some additional clarification, but Bill, clarify, do you think that that's a showstopper for this recommendation or maybe just a minor tweak?
Well, they're just a lot of words and I don't know what it means. I mean, when I read it, it's just I'm left with a big question mark. Yeah.
Okay. Have Carol and Sherry provided some clarification?
Yeah, no, that what they both provided was very helpful, but I'd try to rephrase it to include some of those things.
Okay. So
and I think the CDC knows what the program is. So, yeah.
Okay, so why don't we assume that there might be some room for some minor tweaking? It sounds like when we have concurrence on intent, but maybe some minor work to do in terms of modifying the wording, albeit I think this actually came with heavy scripting from CDC staff. That having been said, I think we shouldn't make assumptions that everyone will understand that. Other comments? Okay, why don't we move ahead to the...
Yeah.
I'm sorry, was there another comment? Please.
No, I was just going to say I don't see any hands.
Yeah.
So
okay.
Please go ahead.
Yeah, I think we've moved beyond the hands and now it's a free-for-all with the microphone, but that's fine. It's more efficient. I welcome that. So the next slide, the next two slides describe a new recommendation that we're presenting that I think many of you may have seen for the first time. It was discussed in the Treatment and Complications Subcommittee and also was a product of the work group that Dr. Herman chaired. And this relates to the development of a quality measure that improves patient safety. And what we're proposing is that a quality measure be developed that focuses on hypoglycemia safety. What I've provided here is a little bit background to provide context. And what this is basically saying is that most quality measures focus on lowering glucose because of the fact that the degree and duration of hyperglycemia are directly related to the risks of diabetes complications. Whereas individuals who have less life expectancy due to age and/or comorbidities are less likely to benefit from tighter control and more likely to be at risk for complications from the consequences of tight control, frequently hypoglycemia. Hypoglycemia is not uncommon, particularly when people are treated with insulin or sulfonylurea medications, and there's ample evidence that it can have attendant harms, such as is listed there: falls, fractures, hospitalizations, death. And as a result of that, clearly older adults with diabetes and those who have limited life expectancy due to comorbidities would benefit from less tight glycemic targets. And so what we are proposing is that CMS develop a quality measure that attends to hypoglycemia risk and therefore allows clinicians and patients to balance the unique characteristics and goals of care of such individuals. And we'll go to the next slide. And this recommendation is proposing that CMS develop and implement a quality measure to assess potential overtreatment, inappropriate treatment, or risk of harm among Medicare beneficiaries with diabetes and life-limiting conditions in order to reduce the incidence of severe hypoglycemia and improve patient safety. Now, before I open this for comment, I'll mention that this also had fairly broad acceptance by key informants and stakeholders. The Endocrine Society has recently published a report that that I and Jasmine Gonzalvo served on in parallel, where we helped develop some proposed quality measures for hypoglycemia safety that would be targeted to older adults with diabetes and life-limiting conditions. And the VA has also ongoing a hypoglycemia safety initiative that uses those same attendant risks for older adults and targets patients for de-intensification of medication when risk for hypoglycemia exceeds benefit from lower A1C. Before we open for comments, Jasmine Gonzalvo, do you have any comments about this? I know we didn't turn to you earlier, but you may, if you do, please feel free.
I don't have anything to add, Paul.
Okay, thank you, Jasmine. So we'll open for comments and feedback about this proposed recommendation.
Naomi, what do you mean by quality measure? I mean, do you want them to develop an instrument for determining whether or not somebody is at risk because of overtreatment and inappropriate, like a paradigm of some sort, or?
It would be basically identifying a clinical parameter that would be targeted and determining both a numerator and a denominator, and then ultimately establishing what might be a reasonable target for such a criterion. I'll ask Bill Herman, you have experience with quality measures. Want to also address Naomi's comments?
Yes, so Naomi, CMS has quality measures by which CMS providers are measured against, and there's a lot of quality improvement activities that go towards achieving certification or achieving thresholds in terms of performance. So the commercial equivalent is the National Committee for Quality Assurance, which has a panel of diabetes quality measures that a lot of health plans focus on quality improvement to address. It's tied to reimbursement and other factors. So it would be to incorporate a measure like this into the ongoing CMS quality measures, which would then generate quality improvement activities across CMS programs.
I'd also add, Bill, this is in primary care, the payers get in on the act with this too, because we get...
Your microphone has been turned on.
Bill, we've only heard a little bit of your feedback. Try again.
Yeah, somebody muted me. I hadn't even made my point yet, and somebody muted me. In primary care, the payers get in on this too. What happens is we get our numerator and denominator, and there's the financial incentives to keep people below. And there are some of the measures where you can put these exclusions in. And this is the way I read this, Paul, was that, you know, you would have an exclusion in there saying this is a patient that has whatever situation is, and they should be excluded from the denominator and determining any sort of incentives for keeping your population under a certain level of control.
So you're correct, Bill. You know, that some of these details are to be determined. In the Endocrine Society recommendation, it was suggested that people with less than 12 years of life expectancy be excluded, anyone in rehabilitation, inpatient hospitalization, long-term care be excluded. And just for clarification, some things that could go into the so-called limited life expectancy conditions might include things like stage 3B or higher, CKD or end-stage kidney disease, dementia or cognitive impairment, cancer, metastatic cancer, chronic liver disease, or things like that. There are a variety of things that could be subsumed into that to be determined, but the idea is that you would not apply this to a healthy 65-year-old who would potentially have 20 or more years life expectancy.
But the underlying principle is that by measuring something and incentivizing performance, you can improve quality and patient safety.
Did we address comments? Carol, I see your hand up. Was that from a previous?
No, but Jana has her hand up too. So.
Oh, my mistake. Jana, please.
Yeah. Hi, thank you. Clarifying question: the limitation of Medicare beneficiaries. I'm reading in an assumption that that's a proxy for the age limitation of 65 or older, since the background of the recommendation really addresses the issue of hypoglycemia in older adults. And I guess it's a two-part question. Number one, is that a safe assumption? And then number two, might there be some benefit in more explicitly calling out the age parameter in the event that this does apply in payer situations beyond Medicare?
Actually, you astutely picked up something that was very carefully worded, and I was going to mention, but actually did not. But thank you for bringing it up. Many people may know that Medicare also covers individuals who are less than age 65, who are permanently disabled. Also, individuals who have end-stage kidney disease or on dialysis are Medicare eligible. And you might expect that some of these same criteria could apply to individuals who, by the nature of their comorbidities, also have limited life expectancy and therefore are not candidates for tight control where the risk exceeds the benefit. So we originally talked about having older age greater than or equal to 65, but then when we thought about those other individuals, we said you could potentially extend to that. So that's why this phrasing was added. It's open for comment as to whether or not that inclusivity is sufficient, or might that be altered.
I mean, I think the percentage of individuals that would be covered by Medicare that aren't 65 or older, I think that's less than a 15% population, and most of which would be covered by other parameters in the recommendation. So I think if it was considered in your wording and recommendation, I don't have any further questions.
Other comments?
Then I just wanted to clarify from Bill Cook if he thought we needed to modify to say develop and implement a quality measure to assess, or add exclusions to existing measures. Were you proposing wording change, Bill Cook, or?
The business of exclusions better. It's harder to implement things on the bottom end, like over-treating people. Like, you'll see people whose hemoglobin A1Cs are like, 6.1 and they're on, glyburide or something, and they've got the potential to get into trouble with hypoglycemia. So that they're harder to pick out, like what's quote unquote too appropriate. But pulling out the people that you shouldn't be trying to push them below certain levels, I think you'd catch more people that way and not be having people inappropriately not placed on the right medicines.
In the past,
negatives in there, I'm sorry.
And Bullock, myself, Clydette, some other people worked with CMS on the hypoglycemia concern. We were told that CMS cannot add the exclusions, that the measure developer has to add the exclusions. Barry, can you comment on that?
Yeah, unfortunately, I'm not familiar enough with measure development to be able to really give an opinion on behalf of the agency. Thank you.
So, Bill and Carol, this is Bill Herman again. I think it's implicit that when you develop a quality measure, there are explicit inclusion and exclusion criteria. So I think that that's covered. And I don't think we want to get into the position of trying to specify them. It's all part of the process.
Yeah, and I believe that the anecdote that Bill Cook cited would potentially be covered in this, where such an individual, if they stood to have more risk than benefit from overtreatment, would potentially no longer have, say, a less than 7 A1C criterion. Any additional comments or feedback about this this recommendation? Well, not hearing none, Dr. Herman, why don't I turn it back to you? Thank you.
Great. Thank you all for a very good presentation and discussion. We're scheduled for a break now. There is no oral public comment today. So the remaining issues on the agenda are a vote on the recommendations and a discussion of preparing the report to Congress. Would people like to take another 5-minute break and then reconvene for the vote? And I guess I see that a number of revised recommendations are coming across. I don't think we have time to revisit each of the recommendations individually, but I think what I'd like to do is vote on the recommendations and the discussion that we've had today. But do people want to push on, or should we take a 5-minute break again?
This is Bill Cook again. The recommendations that were made about insulin, the cost of insulin, I think there was one in the group and then one in the group that you were leading.
Yes, that was now, I think, recommendation 11 for the treatment and complications. So it is there. It wasn't discussed.
Yes.
Let me read that recommendation, and so others will know.
Thank you.
And then we'll welcome your comments. This recommendation, which again was a distillation of work that Dr. Herman did, and actually was a byproduct of work, I should say, that resulted from Bill, Dean, Carol, and me, trying to put this into a format that we thought could be presented to you and would be acceptable to the commission. So the recommendation reads, we recommend that federal policies and programs remove cost barriers to ensure that insulin is affordable for all people with diabetes and that no one with diabetes who needs insulin cannot get it because of cost. So that is the recommendation that we brought forward for you. So, Bill, your comments?
Certainly, if it stands as it is, I'm 100% behind it. One of the problems we have sort of on Main Street taking care of people with diabetes is that they take glimepiride and metformin, and the next step is to put them on, insulin, N and R, because it's all they can afford. And so they wouldn't even be on insulin if we could give them SGLT2 inhibitors and all the other ones that are so expensive. And so, you're winding up dealing with people that can't afford strips and aren't testing their sugar and hypoglycemic episodes, et cetera. And so my question is, and you may well have thoroughly vetted this out in your discussions, is there some way of including oral hypoglycemic agents too for those reasons that I just enumerated?
I'll offer my comments, and then others that were part of the discussion can also offer their feedback. Your point is obviously well taken, that the cost of branded medications in many cases is exorbitant and in some cases prohibitive. We decided to focus on insulin primarily because, for the most part, it's a product that has been in the market for decades. Its cost has gone up by what is it, Bill? Herman, 3 to 5 fold over the last 20 years, despite the fact that the manufacturing process probably has not changed. If anything, has developed even more efficiencies. And there are stories galore of individuals, patients, who have not been able to either take insulin or rationed insulin as a result of cost. There was some concern about migrating into other diabetes treatments for fear that then you'd have to kind of draw some arbitrary line as to, do you stop at glucose-lowering treatments? Do you also include cholesterol-lowering treatments? What about blood pressure medications, et cetera? And therefore, it was more parsimonious to stay with insulin because there was likely to be almost uniform acceptance of the challenge and the problem. Bill, Carol, and Dean, please feel free to comment.
This is Carol. I'll jump in. Also, insulin is life-saving for many people. And we also, if you'll look at recommendation 13, we think some of those medications like the SGLT2 inhibitors are rapidly on their way of being considered high value in keeping people off dialysis, out of the hospital, et cetera. And this is also probably a mechanism for insulin in addition to what we say in recommendation 11. But insulin is a bit unique in that, at least for people with type 1 diabetes and maybe some other forms of diabetes, they can't live without it.
And let me, before others comment, I'll just insert, because Carol referenced recommendation 13. I'll just read that for the group, for those of you who don't have it accessible. And that is, we recommend that HHS establish a process to determine and regularly reevaluate high-value diabetes services and treatments to be fully covered, parentheses, pre-deductible, close parentheses, by health insurance based on their ability to prevent development or progression of diabetes complications. So others may comment about Bill Cook's comment.
So, Bill, I think those two really address your concerns. There was a lot of discussion about looking at more general issues of medication affordability, but and things, as you recall from the work group presentations about patent laws and exclusivity and things like that. But we've elected just not to go there. Some of it may be discussed in the background.
Yeah, I guess considering maybe the audience that's going to be reading and considering this, in 13, if it said services, treatments, and medications, or treatments/medications, just so that it's very obvious, and then I can totally live with the way it would read. Thanks for the explanation. I appreciate it.
I think that could certainly be added. Carol, Paul, Dean?
Yeah. If not, then certainly in the preamble that precedes it or follows it, that could be highlighted. I think that was our intent.
Okay. Why don't we take a 5-minute break and then reconvene for the vote, and I'll go over the ground rules for the voting when we reconvene. So it's let's reconvene at 4:40 Eastern Time. So 7 minutes. Thank you. Okay, we will reconvene now, and I believe we need to do a roll call, so I'll turn it over to Kara to conduct the roll call.
Great, thank you. Welcome back, everyone. So members, just let me know you're here when I call your name. Bill Herman?
Here.
Pat Schumacher?
Here.
Howard Tracer?
Here.
Barry Mark?
Present.
Naomi Fukujawa?
Here.
Naomi Fukujawa?
Yep, I'm here.
Okay. Donald Chow?
Here.
William Chong?
Here.
Aaron Lapata?
Here.
Dana Town?
Did you hear me? I'm sorry. I said.
Oh, Aaron. Yeah, I heard you, Aaron. Thank you. Dana Town?
Yeah.
Present.
Barbara Linder?
And this is.
Here. Captain Samuel Wu? Captain Samuel Wu?
Here.
Thank you. Paul Conlon? Paul Conlon? Ayatunde Dokun? Ayatunde Dokun? Carol Greenlee? David Strogoff?
Present.
Dean Schillinger?
I'm here.
I'm just going to go back and Captain Samuel Wu?
Present.
Thank you. Paul Conlon?
Here.
Ayatunde Dokun?
Here.
Carol Greenlee?
Here.
Thank you. Ellen Lee?
Here.
Jasmine Gonzalez?
I think you just said Jasmine Gonzalvo. I can't tell. It's kind of breaking.
Great. Can somebody please?
And this is Don Shell. Did you capture my attendance?
Yes, thank you, Don.
Thank
John Boltry?
Present.
Meredith Hawkins?
Present.
Shannon Idzik?
Present.
Sherry Bolin?
Present.
Bill Cook?
Here.
Dr. Herman, there's a quorum. Please continue.
Good, all right. May I have the next slide, please?
So just to review the voting, approval of a recommendation will require a simple majority vote. I've broken out the recommendations by the subcommittee and the number that they received in the materials that were circulated. I've given brief sort of high-level summaries of what they're about, just to remind you. What I would propose is that we give people an opportunity to look at the rest of the list of recommendations. If they would like to call one out for an individual vote, we can do that. But otherwise, I would like to recommend that we vote on them as a group if everyone is in agreement and no one wants an individual vote on any specific recommendation. So the recommendations are being revised, have been revised to some degree by the Prevention General Population Committee. I think the intent is that they be revised according to the discussion that we had, but I'm not sure that we can reread each of them. So again, look at this list, see if there is anyone that you would like to recommend for an individual vote, and if not, I would accept a motion to approve the entire panel.
Bill, this is Paul Conlon. May I just ask for a clarification? I think a substantial amount of the discussion today focused on clarifying and in many cases not changing the intent of the recommendation. So I'm reasonably comfortable that most of the recommendations, except if the co-chairs feel that the feedback they received requires them to substantively change the recommendation, that we could vote en bloc, but perhaps based on the feedback received, maybe the co-chairs could at least opine on whether they feel that they need to modify their recommendation substantively.
Yeah, I would agree with you, Paul. I don't think I heard any substantive modifications, but for this panel, I would ask Dean and Aaron whether they feel that any of the substance of these recommendations have been modified.
We made minor modifications based on the feedback, but nothing with respect to the intent and the thrust of the recommendations. Aaron, would you agree?
Yes, I agree with that. Thanks, Dean.
Okay, and would anyone like a vote on an individual recommendation, or shall we vote on them as a panel?
Kara had some FACA regulation.
I have another point of clarification, in that does it occur that we would begin to meld some of these recommendations, because there is some overlap, and how do we know which ones are going into overarching versus staying within a specific subcommittee's set of recommendations?
So the only one that is from this group that is proposed to go into overarching is PGP1, the Office of National Diabetes Policy. Is that correct, Dean and Aaron?
Perspective, I wasn't sure if the healthcare access one was going to be overarching or whether it was going to be unique to treatment and prevention or targeted population.
No, so that was overarching, but that's separate. It's not part of this group.
Bill, this is Paul. I would say that whether or not a recommendation eventually gets reordered, I don't think it would be impacted by our vote today, because assuming we approve it, then as a commission, we would have the ability to move it around in the report to where it best sits if we later realize that it fits better in a different area. But assuming it's approved today, then that would be more tweaking as opposed to substance.
All right, I would agree with that as well.
Naomi, does that address your concern?
That, because I also saw ambient and built environment as being one that I listened to the discussion and thought was going to be another overarching from this group.
Good, and that actually is possible according to what Paul just indicated.
Yeah, correct. And
Okay.
That's fine. Thank you.
So, Carrie, your remarks. Oh, sorry. Go ahead, Barry.
Yeah, I just want to clarify. So we're voting on recommendations that are still under development, correct?
No, we're voting.
Understanding of. Yeah, go ahead.
So we're voting on recommendations that are being wordsmithed at this point based on the discussion today, but there should be no surprises based on the discussion today. We just don't have time to put them all up again and look at the words and discuss them again. I think that the changes that have been made, it was clarified, have not been substantive. It's mainly wording changes, and but we're to vote on the substance of these recommendations.
Hi, thanks, Bill, and thanks, Dean, for. So it just has to be very clear what's being voted on, and if and like Dean and Aaron said, there weren't substantive changes, so those recommendations don't have to be reread. But if someone wants a individual recommendation reread, you can make a motion to have that reread.
So, Bill, Paul Conlon, I will make the first motion, and I will move that the commission accept the recommendations of the Prevention General Population Subcommittee as discussed today.
Good. And is there a second for that?
John Boltry here. I second that.
And all in favor say yes?
Yes.
Yes. Yes.
Yes.
Yes. Yes. Yes.
And all opposed, please say no. And anyone who has abstained, please say abstain.
This is Bill Chong. I'm going to.
So it sounds like, excuse me?
This is Bill
So
Chong.
we have one abstention?
Yeah.
Okay. So we have votes in favor with one abstention. Good. So let's go on to the next panel then. Next slide, please. So these are the prevention targeted population recommendations. Again, if anyone would like a specific recommendation reread to the extent that it has been revised, we can do that. If anyone would like to call out a recommendation for an individual vote, we can do that. Or hearing nothing, we can vote on them as a group in a minute or two. So take a look and let us know.
Bill, this is John. The discussion today to move the last sentence from the background on type 2 diabetes to a recommendation, will that be voted on next time then, or what was the idea there?
Yeah. No, so that change would be incorporated in the recommendation, and that was recommendation 13, is that right?
That would fall under the research, yes.
Okay.
And if anyone wants, like, I can read a draft of that, which we still haven't completely vetted, but let me know.
Would anyone like to hear that, or are you satisfied with the discussion we had today? And to follow up on the discussion today, metformin for prevention is still listed as a recommendation, PTP 5.
Hi, Dr. Herman. This is Phil. I would like to propose that one get a line vote.
Okay, hearing nothing more. Go ahead.
Bill, there's a couple.
I just wanted to be sure. I like David's suggestion of putting, I guess it was 4.
That's right. Yeah.
Tying it into 3. I really liked his suggestion. If we vote on it as 4, it doesn't have to stay that way. Is that right, or do we need to call that out?
Thank you for calling that out. I think the intent is to combine 4 with 3. David, do you want to just clarify that?
Yeah, that's correct.
So actually 4 would be withdrawn and it would be part of 3 now. Thanks, Carol. Anything else? Okay, can I have a motion then to approve these?
Hold on. Bill, you have Bill Chong who's trying to say something.
This is Carol. I make a motion to approve this panel of recommendations.
You have Bill Chong trying to say something.
He wants to read the metformin one.
Dr. Herman, can you hear me?
I can now. Yes, go ahead, please.
Yeah, I'd like to ask that the metformin for prevention be voted on separately.
Okay. So
you should make the motion.
Is there any, well, I think we discussed it before. Okay, so do you want to make the motion that it be voted on separately?
Motion that PTP 5 be voted on separate.
Okay, and is there a second?
I second that.
Okay, and all in favor of approving PTP 5 to look at, to ask, I guess, FDA or to put together information for FDA to review metformin for diabetes prevention. All in favor of that recommendation, please say yes.
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 Yes. Yes. Yes.
Yes.
And all opposed to that recommendation, please say no.
No.
And all abstaining, please say abstain.
I abstain because this is Carol. I thought it was the NIH, not the FDA. So I'm now.
Yeah, okay. Well, I misspoke. So the NIH to put together information for a responsible party to submit an application to the FDA for approval of metformin. Do you still want to abstain? I misstated the
I'll still
proposal.
Abstain. Yep.
And I did not hear any objection, so we have just one abstention. Is that correct?
Was an objection.
Was there a no vote on this?
Yes, there was.
Okay. So we have one no vote and one abstention.
Another abstention.
Okay.
Abstain.
Yes, I abstain.
Okay. So 2 abstentions and 1 no vote on this motion. So the motion would still carry, but let the minutes note the vote. And can we now have a motion to approve the other recommendations as presented previously? And a second?
I second that.
Second.
All in favor, please say yes.
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 All opposed, please say no. And all abstaining, please say abstain. So I'm having problems with my audio, but it sounds like that was unanimous for the rest of the panel. Is that correct?
Yes.
Okay.
Yes.
All right, let's go on to the next slide then.
Raise our hand.
And these
with the
On a laptop.
So these are the recommendations from treatment and complications. Is there anyone who would like any individual recommendation read?
This is Dean. I'm sorry, I asked this question during the TNC presentation, but I think my audio was not audible. So this is to Paul and Carol. I remember earlier versions of recommendations where there were recommendations around extending the telehealth and telephone visit coverage for patients with diabetes. Did that get folded into one of the existing recommendations, or has that been dropped, or am I just misremembering?
We've moved that. Can you hear me? I know there's a lag.
Yes.
We moved that back to the report to support, because there are at least 4, if not more, bills in the House and Senate right now that every single one of them asks for what we ask for. And there's almost no likelihood that something isn't going to get passed. So we've been in communication with the AMA around this, and we moved it back to strongly support. But it looks like it's probably going to be passed before our report comes out. So that's why we moved it.
And if it's not passed?
Well, I don't, you mean if all those bills either haven't gone forward or all of them get rejected?
Yes, which is not an unlikely event.
This is Paul Conlon. We were advised by an external informant of the bipartisan commission that generally Congress prefers that advisory committees acknowledge their Congress's action and doesn't necessarily recommend things that Congress is already in process. And so that was why, in a way, we decided to defer this to a suggestion as opposed to a recommendation or an affirmation. And then the second thing is it may be presumptuous to think that if all of those bills go up in smoke, that a recommendation by the NCC will tip the balance and cause that to actually come back as legislation. So we opted not to make it a formal recommendation, but a strong support for.
Understanding of that advice, we've also received that advice, Paul, is that if Congress has already accomplished something, is already doing something good, in our mind, positive, that we should not make a recommendation that they do that, because it undermines our trust in them, because we weren't aware of what it was that they were doing. I was not aware that pending legislation or potential pending legislation was an area that making a recommendation around would be something we would want to avoid. And I'm only raising it because it is such a mom and apple pie recommendation. I just don't want us to lose sight of that because of some advice that we may have misinterpreted or not. So I apologize for raising it at this late time.
Well, let me ask Dr. Herman and Kara, would this be one of the things, if we get to September, that recommendation was simple, straightforward, that we would it would be one of those, the ones we have to vote on September 8th if we need to resurrect it. Because I don't know.
So it seems to me that
now. Go ahead.
Yeah, I was going to say the two options would be to put it in now and then take it out in September if it was unnecessary, or as you said, we could leave it out now with the idea of putting it in and voting on it again in September. I think it would be better to have it in and take it out, but we could maybe plan to write it in and vote on it in September.
Hi, Bill. Can I jump in here? The best option would be not to leave it out or put it back in, because we're really considering this as a final vote. What we have suggested before, because it helps the policymakers or our congressional audience follow the progression of how the recommendations came to be, it would be best to perhaps leave it in, but like Carol and Paul suggested, if the bill goes through as you believe it will, then what you do is you put that in the report and say this was voted on, we had it in the final vote for the June 22nd meeting, but it became no longer valid since it was already the bill was already passed. So you put that in the report, and it really helps the congressional audience follow the process. That's why it's not just the vote or not vote. You could also decide to leave the recommendation as is for September 8th and just write how the process came about without making any changes.
So the recommendation was that the restrictions that were lifted by the public health emergency waivers, and CMS can't do this, it has to be done by Congress for geographic and site restrictions, that those remain lifted permanently, that federally qualified health centers, rural health centers, be allowed to do telehealth visits, that diabetes support, self-management support, and education continue to be allowed to do telehealth visits, and that audio-only visits be allowed to continue. So those were the components of the telehealth recommendation, if we're adding it sight unseen today.
And was that was that part of one of these 13 recommendations, or was it taken out entirely?
It was its own recommendation, and it was removed.
So I think we discussed that in some detail at the earlier meeting in June. Can we add that back based on your summary as TC14 and vote on it? Do you have the exact wording? Can you read it now for everyone?
Bill, this is Paul. I have it from the slide deck that we used from the previous meeting where this was discussed. So Dean's
can you read it then?
I will.
So this is TC14, so please go ahead.
Okay. We recommend that Congress should, 1, remove geographic and originating site restrictions so that CMS can provide access to telehealth services as appropriate. 2, make permanent the ability for federally qualified health centers and rural health centers to provide services by telehealth. 3, make permanent the telehealth waiver for DSMES/DSMT. And 4, maintain coverage for audio-only visits as necessary to comply with the executive order on advancing racial equity and support for underserved communities.
Okay, and can we have a vote on that recommendation now, and then we'll vote on the others? A motion to support that recommendation.
This is Ayatunde. I move to support the recommendation.
And a second?
Second.
I second the recommendation.
And all in favor, please say aye. Aye.
Aye.
Aye.
Aye. Aye.
And all opposed, please say no. And all abstaining, please say abstain.
Abstain.
Okay. Good. So we have approved that, and we can handle that moving forward, as Kara had indicated. Waiting to see what happens with the legislation, though the fact that there were so many components, it seems to me quite possible that some, but not all, may be picked up in legislation. Okay. And now for 1 through 13, can I have a motion to approve?
So moved, John Boltry.
And a second?
Second.
And all in favor say aye.
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 Aye. Aye.
And
Aye.
Aye.
And opposed, please say no. And any abstentions, please say abstain.
Abstain.
Okay, great. Good. And if I can have the next slide. The last recommendation was access to care. Can I have a motion to approve that?
I move to approve it. Dean Schillinger.
And a second?
Second.
All in favor, please say aye.
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 Aye. Aye.
Aye.
And opposed, please say no. And abstentions, please say abstain. Okay, great. All right, thank you. May I have the next slide, please? So the final agenda item is the structure and format of our report to Congress, the timeline for writing, and the writing group assignments. And so a number of us have met as the co-chairs group with folks from the Office of Women's Health, as well as with Jennifer, to draft an outline for the report. And I'll go through that quickly, and then we can discuss it. So if I can have the next slide. Go ahead. So we thought that the report would include first a table of contents and an executive summary, and then a chapter describing the background of the NCCC, which would summarize the congressional authority, the establishment of the National Clinical Care Commission, our formal charge, and our approach to the charge, focusing primarily on the socio-ecological diabetes prevention and care model as the basis for our deliberations and recommendations, and the need for access to comprehensive, high quality, and affordable health care for all people at risk for and with diabetes. Next slide, please. We thought then the next chapter would focus on methods, which would include the commission and subcommittee structure with the 3 subcommittees, and information gathering and assessment, including the relevant agencies that we have targeted, the data call, stakeholder input, key informants, and the literature search and review of the results of the literature search. Next slide. The substantive chapters would be from the subcommittees. The first, the population level diabetes prevention and control, from the Prevention General Population Subcommittee. And each subcommittee chapter would have a background section and then the specific recommendations that we just voted on. For this chapter, the background would highlight the epidemic of diabetes in the U.S., including its costs, describe the complementarity between population-level prevention and control and individual-level approaches, and link population-level diabetes prevention and control with obesity, cardiovascular disease, COVID, environmental exposure, social determinants of health, and health equity, all to support the Commission and subcommittee's approach. Then the individual recommendations would be listed with the background and rationale, and then the specific recommendation as voted on and approved. Next slide.
Bill, can I ask a question about?
The same would be for the targeted interventions. Forward again.
Hi,
Bill,
Bill. Somebody wanted to ask.
Bill, can you hear me?
Have the next slide, please.
Hi.
Bill, can you hear
Bill?
me?
Yes.
Somebody wants to ask a question.
No, I'm not here. So is there a question?
Kara, you're breaking up badly.
Bill, can you hear me? It's Dean Schillinger.
I can now, yes.
So on Chapter 3, and this is relevant to all the three subcommittees, there has been a recommendation that rather than have very lengthy recommendations, that in some instances we would want to provide guidance language, or as Carol, I think has called it, examples and detail that would have to logically flow after the recommendation. They would not be in the background. So I just am wondering whether we are going to add a bullet point after each topic. After recommendation 3.1, for example, would there be the opportunity to provide some clarifying examples?
Sure, as long as it's succinct and actionable. I don't believe I would be the final arbiter on that, but what do people think? Makes sense to me.
Yeah, I this is Ellen. I wholeheartedly endorse that. If you look at the report on tick-borne disease, really the emotional pull were in the vignettes or the patient stories.
Yes, this is Meredith, and I wholeheartedly agree with Ellen. I found that tick-borne disease brochure to be very moving, and it's not even my area of passion or interest. But so if only this could be done for such a topic as diabetes, it would be extremely powerful.
This is Anthony. I think an opportunity to also clarify on some of the issues we raised earlier, where linking the recommendation to why, giving an opportunity for people to understand why that particular recommendation is important. I think that that'd be an opportunity that'd be an area where one can take care of.
So for each topic, then we would have a background, rationale, a recommendation, and what would we call that? Vignettes, elaboration, explanation? What is there a term that people would like to?
I was thinking about, I was thinking about additional guidance. Carol has used the term examples. I don't know that we have to decide. I just want to make sure that we have a placeholder that is not called recommendation, because we have just voted on it.
Okay, but the recommendation would be there. There would be a background, rationale, or recommendation, and then something more to elaborate on it. Right?
Yes.
Is that what you're suggesting?
Yes, and just
exactly.
Yeah, and I think that subcommittees, this is Sherry, may want to think about which ones they do that for, because I do think it was powerful. I also think that we have 30, more than 30 recommendations. So I think if that's there for every single one, it gets a bit long.
Right. But I think where it might go is
I think for those that it's applicable for some, the rationale why we're making this recommendation will be all that's needed, and for others, there may be or that guidance could be tied into the rationale. But
yes, now I think for example,
we need to allow for the guidance and details if needed.
Yes, for example, on the slide that you're showing right now.
Recommendation for each of them, we'll put guidance, details, vignettes as needed.
As needed, that's right. For example, on the slide you're showing right now.
Does that address your initial question?
Yes, Bill, but Meredith is speaking.
Yes, thank you. On this, just as an example, when it comes to questioning where to put the vignettes, just as an example, on the slide we're looking at right now. Okay, can you hear me now? Can you hear me now?
Yes, we can.
Thank you. So, for example, in terms of where to place the vignettes, I agree we do not want to overdo this. Just a few, very well placed. But I'm thinking, for example, on the slide you're showing right now, under the general background, rather than under the specific topics, let's say, but a powerful vignette that would address the overarching aim of that particular section. In terms of the examples, I take that to mean particular cases where we might add additional emphasis or power to the recommendations we're making by making them not sound generic, but giving these people an idea of some examples that have been very successful, for instance, in other areas, or things that have been regionally successful, let's say. But there too, I would suggest judicious use of them, of course, as everyone is saying. But I think they could be powerful.
I've lost the audio again.
Yeah, me too.
Yep, well, yeah, many of us can hear. Yep, same issue.
Meredith, are you still on?
No, I finished. Did you hear?
Okay.
Did you hear?
Okay. I heard it to a point. Yes, I think so. Okay, let's go on to the next slide if we can. So this was, again, a similar outline. We would make the same changes as discussed. Here, the background would be definition of prediabetes, epidemiology, screening, and then targeted interventions to prevent diabetes, including lifestyle and medication interventions, and effectiveness and cost-effectiveness of diabetes prevention. I think to include some compelling vignettes or stories here would also be important, and then the recommendations would appear with background rationale recommendations and then the guidance or the elaboration. John or Howard, comments on that?
Sure, it's Howard. If you can hear me. Just the title of the chapter, and maybe we don't have to decide that right now, but it's not so much targeted interventions to prevent diabetes, it's interventions to prevent diabetes in a high-risk targeted population, because that can be misinterpreted. So just make it clear that we're talking about people with prediabetes.
Okay. All right, let's go to the next slide. And this is for treatment and complications. The outline that Carol and Paul provided was slightly different. They broke their background into two parts. First, providing an overview of treatments to prevent complications and interventions to treat complications and the current levels of performance, focusing on federal efforts supporting clinicians in providing integrated high-quality care to individuals with diabetes and its complications, highlight promising programs, and then prevent the recommendations to enhance, expand those programs. And the second part on the next slide. Next slide, please. Was to highlight gaps in federal policies and programs affecting clinicians in providing integrated high-quality care to individuals with diabetes and its complications, highlight the key issues and barriers affecting clinicians' ability to provide high-quality care to individuals with diabetes and its complications, and then the recommendations to address the issues and barriers. So, Carol or Paul, any comments on this?
I have none. Carol, to you?
I don't either.
Good. And so this is a little different model. So I think the other co-chairs and subcommittees, if you want to modify what you've done along these lines, that would be fine too. The next slide was a placeholder, really, Chapter 6, research needs. Currently, the research needs are included within the individual subcommittee chapters. We can pull them out if we think that that's desirable, or leave them where they are. The thought in terms of pulling them out was that people making decisions about research may be different than people making decisions about policy and programs. So it could be here, it could be within the chapters, or we could put research needs as an appendix. Any thoughts about that? If it were the appendix, it would be in the subcommittee chapters and then probably combined in the appendix as well.
I think it is well positioned here, Bill.
So would you pull the research recommendations out of the subcommittee chapters?
Yes, we would present them in aggregate. We could still organize them based on committee, but present them in aggregate makes sense.
Okay, are folks in agreement with that? Any other thoughts?
We need to think about that for a minute. It sounds good, but go ahead. Sorry.
No, you finish. Go ahead.
Yeah, that's all I was saying, John Bolster. I just need to think about that for a minute and process that.
So I was just going to say that my concern about that, I mean, on the one hand, I think it does make a certain amount of sense to group them, but, you know, in the chapters, they follow based on the background in each chapter. And if you're not going to repeat that background, then will sort of the rationale and the importance get lost because they're separated from their background.
So do you think the background, though, could be pulled from the chapters without damaging the chapters and all put here?
I don't know. I mean, I'd have to sit and look at the whole thing.
Okay.
I mean, is that something we can decide later? You know.
Yeah, let's leave that for further reflection. We may end up sending an email out to solicit people's thoughts on that. Chapter 7 then was the National Diabetes Strategy, and this is what we had talked about before, pulling some of the recommendations, including the Office of National Diabetes Policy, potentially the HHS thing, and then the other recommendations that were discussed today into a separate chapter with an emphasis on improving patient outcomes and population health across subcommittee work.
So, Bill, this is Dean. I wanted to make a comment.
This is Sherry. The only thing it makes it sound like there's some things in our subgroups that are not National Diabetes Strategy, and there probably are. And so I guess I'm just wondering if it needs to be labeled something different, like overarching strategies that apply to all three subcommittees is a very long title, but I think that's more the title as opposed to if we're going to have other overarching things, it just makes it sound like some of the things that are also national under our subcommittees are not national by having a separate chapter labeled that way.
Excellent point. I agree entirely. So we need a different title. Yeah. Go ahead, Dean.
Yeah, I want to amplify what Sherry is saying. I think the way we envisioned this chapter originally was not that it would be the home to a specific recommendation or two only, but that actually what we were putting forward was, in its totality, actually an updated national diabetes strategy and action plan, because the last time that was done was 1974, and we've been living our world of diabetes as if we're in 1974. And so everything we have been describing in chapters 2 through 6 essentially represent what we would like to put forward as a national diabetes strategy, including this comprehensive Office of National Diabetes Policy and other cross-cutting issues. But I think this is the summation rather than something new. In other words, is our report, in a way, the blueprint for a national diabetes strategy?
So you might bring in things from the subcommittee piece into this, or you would refer back to?
I think everything we just voted on would be part of what we would recommend a national diabetes strategy contain.
That sounds good.
Would that be redundant?
I guess I was just thinking about there were several overarching recommendations that weren't going to fall into a specific subcommittee. It seemed like there might be more than one, and I guess you would just have to think about that in this chapter, or that might be a separate chapter. It's a little hard to know based on the discussion today.
Yeah, I mean, I think the challenge is where we're positioning this chapter. I mean, to me, this chapter in some way should be the first chapter we write, or something that says what we're presenting here could be part of a blueprint for a national diabetes strategy to update the one from 1974. Whether that should also contain these additional recommendations, these one or two, I think is a secondary point. And I agree we might want to put those at the end or the beginning. But I think, but this may not be what the commission is thinking, but I think we want to basically create the framework that the recommendations that each of our subcommittees is making are complementary and part of a national plan to tackle this epidemic.
So this would not include individual recommendations, but would try to integrate it all together. The next chapter, if you can go to the next slide, was listed as conclusions, and maybe conclusions actually would be part of this national diabetes strategy as well. Would these things be part of your national diabetes strategy, Dean, as you envision it?
The perfect place to have the statements made that we believe this aggregate of our 30 recommendations or whatever it is could be the blueprint for a national diabetes strategy, and there may be more that we haven't considered. So yes, maybe Chapter 7 would be just those additional recommendations, and Chapter 8 would be about the national strategy and action plan. If that makes sense, that could work as well.
So that's what they're retitled.
So I don't want to.
So Chapter 7 would be cross-cutting issues, and then Chapter 8, the conclusions, could be retitled National Diabetes Strategy and Action Plan, which would be more conclusions.
I think it's recommendations for, right? I don't think it's the blueprint for, as Dean keeps saying, a national strategy, but it is not formalized into a national strategy. So you could
right, and in the recommendation in the chapter before, we're going to say we recommend that that someone make a national strategy, and that is the ONDP recommendation. So I think it would make sense to follow it up with that.
Does that sound okay to people?
This is Sherry. That seems reasonable. I'm reading Carol's comment also. I was having similar thoughts about the equity recommendation should likely go into overarching. So I'll let the subcommittee chairs figure out what they think should be in the cross-cutting chapter. Sorry about the echo.
Yeah, Carol, good point though. So equities would certainly fit in that as well, in the cross-cutting issues.
Bill, this may be one of those, like we just which is we may need a little more time to process and weigh the pros and cons around how to frame it and place it and name it. But
okay, we're going to need to do this fairly quickly. Time is relatively short, so I think we'll have to send this around for comments. The last piece of the report was appendices. It might make more sense to include the grid linking the recommendations to the charge of the NCCC in the appendix, or it could be part of the conclusions, depending on how we write that. But the appendices then were listed there. Are there other thoughts in terms of what should be in the appendix?
I just wanted to ask Clydette if she believes the NIH search terms that we would make transparent what the searches that we did for our literature review. Is that feasible, Clydette?
Hi, Dean. Can you hear me?
Yes.
Yes, I would say yes to that.
Good. And we had listed in the methods the search, but you're right. I think we would talk in general about the search and the methods, and then we could include the search terms in the appendix. Good. Okay. So I think based on the discussion, what we'll do is revise this and then send it out for comments. I think it's important that we lock in on it pretty quickly so that people can commence writing.
And
the
Bill,
next slide actually.
Bill, can I interrupt?
The next slide.
Or Kara, can you hear me?
To that, and this.
Yeah, Dean, we can hear you. Bill, Dean
yes,
has a question or comment.
Go ahead,
were you going to include an executive summary or sort of crib sheet for the congressional staffers that wouldn't require them to read the long document?
Yeah, that's the second item. So it's table of contents and executive summary at the beginning before chapter 1.
Okay, thank you.
Yeah, before chapter 1.
This is Jasmine. I have a comment. I wonder if it would be helpful to include in the appendices any recommendations or topics that perhaps were considered but didn't make the final cut.
I like that. What do others think?
For us to do that in an accurate fashion, speaking from our subcommittee, we would have to define the terms.
And I suggest that just based on being comprehensive and perhaps for people who may have provided comments and they don't see their comments reflected specifically. And so perhaps it's kind of a concise kind of topic listing versus a descriptive narrative of all of the topics. But just a suggestion in case we want to be comprehensive in that direction.
I think it would be desirable.
Well, treatment and complications looked at a lot of very promising programs, policies, initiatives that we didn't make formal recommendations around that I've been making a list of that we would call out in our chapter. For instance, the VA Department of Defense Virtual Medical Center, e-consultations, the FDA, the device department, I forget the abbreviation right now, that they've just made amazing changes that have sped up the approval, not the eligibility, that's CMS, but the approval process for devices. So there are a lot of things like that that we were going to call out in the chapter, but we didn't make recommendations because they were already like on their way or didn't really fit under a federal government, that federal agency.
So I was going to say, I think it would be important to do this. We may have some difficulty doing it systematically if other groups did not keep a list like Carol necessarily. In Chapter 8 conclusions, it does say discuss issues, challenges, and feasibility of recommendations. So that might also include some discussion of things that we did not recommend and the reasons why we didn't. It would seem to me could be included there as well, though we could include a more thorough listing in the appendices. What do people think of that?
Okay.
You know, Bill,
so that might be another approach, but we, I think, have this on our agenda now.
Bill, this is Dean. I want to put forward a contrarian view.
Okay, we only have about 20 minutes left. Let's go to the next topic, which is the timeline.
Bill, can you hear people? Bill, can you hear people?
Dean has a comment.
No, I can hear you, but no one else.
Okay.
Well,
Dean had a
yes, so the contrarian view is sometimes being more transparent in this way can create more problems for us. So let's
Dean,
say
can you go ahead? I'm not hearing you.
Yeah, I'm speaking, so I'll speaking to the rest of the commission. We may say, yeah, we chose not to focus on type 1 diabetes for this recommendation because we just didn't do it. That may be more of a red flag than simply not talking about the fact that we didn't focus on type 1 juvenile diabetes for this particular recommendation. I appreciate
Dean, I'm not hearing anything.
I appreciate Jasmine's sentiment, and I share it in principle, but my experience has been sometimes being more communication can sometimes beget more problems.
Dean, I didn't hear any of that. Can you repeat it quickly?
I would, but I don't think you're hearing me.
Can you hear me, Dr. Herman?
Yeah.
Dr. Herman says, from what I understood of Dean's comment was that just to be cautious that potentially including more information may actually cause more problems, and commenting about things that we didn't consider or provide those things may actually cause more issues. I think that was the point that he was trying to make.
Okay, who was it Sherry who recommended that we include, or was it Naomi? I'm not sure. Who recommended that we include more?
I think that was Jasmine.
Yeah, it was me.
And
I can see both sides. I think that it is just, if we do end up considering including something to sort of detail to whatever degree things that we considered to include but didn't end up making it, I think that it could allay some questions of why this wasn't included and potentially allay some criticism for why things weren't included. Although I can see both points.
Okay, so we'll need to consider that moving forward. Okay. Let's go to the timeline now, if we can. And we are really on a tight timeline. We've modified this and tried to ensure that there is as much time as possible to write the content. But even with the most optimistic scenario, we have less than 2 months to complete the report. So we really need a final chapter to the scientific writer by August 20th. And what we've proposed is that the chapter content be reviewed approximately twice a month by the writing groups, shared broadly, edited, and also shared with the scientific writer, who can offer suggestions as we go along. We would want to turn over the content to the writer-editor by August 20th, giving her only about 2 weeks to actually put it into a report for the commission to review. The commission then would have a few days to provide comments and edits to the final report before the report is voted on at a September 8th meeting. After that, there would be additional copy editing and processing, such that that would be completed by September 17th. We would be able to give HHS a courtesy copy by September 24th. And according to our enabling legislation, it must be submitted no later than September 30th, 2021. If we could move any of this up, I think it would be desirable, certainly, to have some chapters completed before August 20th. But I think this is as generous as we can be with the subcommittee's work. Are there comments on this or thoughts from anyone? And Jennifer and Kara, if you want to chime in, feel free.
Yeah, so this is Jennifer. There's a lot that goes into this for getting the report to Congress concluded. So as much as we can get done, you know, it is sprinting at this point, and is going to be a lot of work between now and September 20th. We'll set up calls for each of the writing groups so that you can review the items back and forth, and there'll be a lot more writing and editing through email.
Other comments on this, and we will send this out so everybody has it and can post it above their desk, and we'll be sending reminders out regularly about pending deadlines.
Bill, can you hear me? This is Dean.
Okay. Can I have the next slide?
Bill, can you hear me? This is Kara.
I can hear you now. Go ahead.
Dean,
Kara.
I think Dean's up for a question.
No, Kara, maybe you could just convey my sentiment that I believe the writing will go quickly because we have written the backgrounds, we have written the recommendations. I want to just communicate that I don't think we should sway much beyond what we've already done in the work of preparing this report. I think we don't need to create more work for ourselves.
Jennifer, would you like to answer that? I'd like to defer to Jennifer with her experience.
Yeah, some of the writing has been done, but not in the way for the chapters. But we'll go through and work with each of the writing groups so that there's uniformity, so there's not a ton of reformatting and restructuring that we have to do. So after this, that's what we'll work on and get to you so that you can commence the writing.
And this is why we'd like to have the scientific writer involved as the chapters are written, to make them so they'll be easier to combine at the end of the day. And Dean, I thought you were going to volunteer then to have that chapter done by August 1st. Is that where you were going with your comments?
Well, since you can't hear me, I won't answer.
Okay. All right. The last item we have, the last item we have on the agenda is the writing group leads. And I've taken a stab at this. I've not run this past anyone. This is just to get the discussion going, so don't, I'm not trying to exclude anyone or push anything one way or the other. I would see the leads actually as for each of these chapters involving others as well. But these were my thoughts. I thought that obviously the subcommittees should write chapters 3, 4, and 5, and I thought we would leave the organization of the writing within the subcommittees to those subcommittees to discuss. The research needs will also need to be coordinated by the subcommittees. The National Diabetes Strategy has been discussed by the chair, co-chairs, and actually a number of members of the various subcommittees, so that needs to be done within that group. I wondered, and I have not asked, whether some of the methods and appendices in terms of just the meetings and contacts and literature searches and things could be done by Clydette or Kara or Jennifer. Would that be feasible for you all to take the lead with chapters 2 and 9?
So, Bill, this is Jennifer. So, yes. So, Yanni and I would draft up those and send them over for review.
Okay. And does anyone have any comments or suggestions with respect to the leads for the other chapters?
I just put my suggestion in the comment box so people could hear that in a different way.
So Dean says in the chat that he would like to be involved in the background chapter. Co-chairs should also be invited or their designees.
Sure, that sounds perfectly appropriate. And if there are other individuals who want to volunteer, I think that's fine. Okay, I'm not sure of my audio. Is someone trying to speak now?
No, no one was making any additional comments.
Okay, so we'll use this as a draft with the suggestions that were made and also send that around for comments and to begin to flesh out the writing group leads. I think the more specific we can be in terms of assigning recommendations to flesh out, the better. Okay, so I think that was the substance of what we had on the agenda. We have a few minutes left. I think we've accomplished a lot today. Kara, did you want to make any comments at this point?
No, I think this has been an excellent meeting. Thank you everyone for your participation. And Bill, if you want to do the final close and then I can do the official close, that would be great.
Okay. Well, so we've covered a lot today. I'm really glad that we've been able to come to consensus on the recommendations. It sounds like we have a good outline for the report, and we're aware of the timeline. We've got to start in terms of putting together the writing groups. We need to push on. We need to keep this momentum going. We really don't have the luxury to take any time off at this point, so I would just encourage people to keep things moving forward at the pace we have over the last few weeks. Kara?
Great. Okay, so with that, we can adjourn the meeting.
Thank you.
Great. Thank you, everybody, for a tremendous meeting.
Thank you.
And a huge amount of work. It's been great. Thank you.
Thank you, Bill.